Hey everyone, welcome back to the Ibato kay Doc Bato Unmasked edition. Today we're diving into hyperkalemia, one of the most common and potentially dangerous electrolyte imbalances you'll encounter. Stick around because I'll walk you through how to recognize, confirm, and treat hyperkalemia efficiently. Let's get started. First, let's talk about where potassium is in the body. About 98% of potassium is inside our cells, with only 2% floating around in the extracellular space. Think of this like a triangle, tiny tip on top, massive base below. Even small shifts in that extracellular portion can have major clinical consequences, especially for the heart. That's why minor changes in serum potassium can be life-threatening. So how do you know when to panic? The big red flags are circulatory collapse and respiratory compromise. In hyperkalemia, watch out for arrhythmias, peak T waves, widened QRS, or even a sine wave pattern before cardiac arrest. Even so, with severe hyperkalemia, it weakens muscles, including the diaphragm, leading to respiratory failure. If you see these signs, act fast. Now let's talk about ECG changes. A lot of people think that ECG patterns reliably reflect serum potassium levels, but studies have shown that's not always true. While we often associate peak T waves with hyperkalemia, these findings aren't consistently present. In fact, ECG sensitivity for severe potassium abnormalities can be as low as 20%, which means that a normal ECG does not rule out dangerous hyperkalemia. That's why you should never rely solely on ECG findings when making treatment decisions. You have to consider the entire clinical picture, like oliguric patients. But then again, it is highly specific, such that the presence of peak T waves means hyperkalemia. Before jumping to treatment, make sure the potassium abnormality is real. Pseudo-hyperkalemia can happen if blood samples hemolyze or if the sample sits too long before processing. If the result doesn't fit the clinical picture, confirm with a plasma potassium test. Before reacting to it, always ask, is there adequate urine output? The kidneys have two key mechanisms to excrete potassium: urine flow and sodium delivery. Increased urine flow washes away secreted potassium, maintaining the concentration gradient. At the same time, high sodium delivery to the distal nephron enhances sodium reabsorption, creating a favorable electrical gradient for potassium secretion. If urine output is good, these mechanisms are at work, so don't panic. But if the patient is oliguric, even a modest rise in potassium can be dangerous. Without flow and sodium delivery, potassium secretion fails and levels can spike quickly. So our teaching point, with good urine output, the body is already protecting itself. But if the patient is oliguric, act fast, even for mild hyperkalemia. The first step in management is to stop any medications that could be contributing to the problem, or discontinue all sources of potassium, whether from the IV or diet. Then protect the heart. Give calcium gluconate. It doesn't lower potassium, but stabilizes cardiac membranes. Next, shift potassium into cells, the go-to combo, insulin and dextrose, with the following doses. Beta-2 agonists like nebulized salbutamol also help but may not be reliable alone, especially in patients with heart failure. Finally, remove potassium. Loop diuretics if with adequate kidney function, and sodium polystyrene sulfonate or dialysis in severe cases can help get potassium out for good. That's it for today. If you found this helpful, like, subscribe, and drop any questions in the comments. Stay curious, stay sharp, and I'll see you in the next one.